speakers to come up, please, because there may be some questions. And while they're coming up, we're going to go through the post-test. That's your yellow paper on your table. Maybe get the slides up there as well. And we're just going to take a few minutes. We're going to go through it. And this is a chance for us to see if we were effective in transmitting some of this information to you. So it will help us to see if we achieved our objectives. It's absolutely anonymous. Don't put your names on it. But it would help me if you wrote whether you took the pre-test or not, if you could note that on there. So the first question is, the electrosurgical generator converts standard frequency alternating current from the wall to what? Is it alternating current with a frequency between 20 and 30 kilohertz? Is it direct current? Is it thermal energy in the tip of any small surface area electrode attached to the output port of the generator? Is it converting it to alternating current with a frequency of between 300,000 and 500,000 hertz? Or is it none of the above? Okay, the next question is, during a laparoscopic cholecystectomy, the active L-hook monopolar electrode touches the laparoscope, which was inserted through an assistance port. And there's an image of that. Which do you think best describes the mechanism of injury that may result? Is this capacitive coupling? Is this an insulation failure? Is this direct coupling? Is this restricted return path? Or is this a case of direct thermal injury? Okay, for the third question, which statement is true regarding temperature in the tissue near or adjacent to the electrodes? A, temperature decreases as the time of electrode activation increases. Or B, temperature decreases as the surface area of the dispersive electrode decreases. C, temperature increases as the surface area of the active electrode decreases. Or temperature change is not related to current density. We heard a lot about this earlier today. Question number 4. Regarding bipolar vessel sealing devices, which of the following is true? A, there are several proprietary devices, FDA approved for sealing vessels up to 7 millimeters in diameter. B, in porcine models, failure rates for larger vessels compared to smaller vessels are basically the same for all devices, or are similar for all devices. C, the time for vessel sealing is essentially the same for all FDA approved devices. Or D, the instruments can be used in cutting, blend, or coag modes. Question number 5. Which of the following is not a cause of incomplete lesion destruction with radiofrequency ablation? So pick the false answer. A, inadequate placement of the active electrode. B, presence of a heat sink. C, inadequate size of ablation zone. Or D, ablation time too long, which is false. Question number 6. How does the use of argon plasma coagulation in the GI tract differ from that during open surgery? A, it uses monopolar instruments. B, it uses bipolar instruments. C, argon gas can overdistend the GI tract. D, they must be careful to touch the probe to the mucosa for the device to work properly. E, can paint surfaces quickly to achieve hemostasis. How does it differ when it's used endoscopically compared to open surgery? Question number 7. In the ultrasonic generator, electrical energy is converted in the handpiece into A, monopolar energy, B, bipolar energy, C, microwave energy, D, mechanical energy, or E, argon beam energy. Question number 8, which of the following tissue types is easiest to fragment with the CUSA device? Is it a ligament? Is it artery? Is it nerve? Is it fat? Or is it bile duct? Which of those is easiest to fragment with the CUSA? Question number 9, regarding microwave ablation of liver tumors, which of the following is false? There are several microwave frequencies available with different tissue penetration effects. B, in microwave ablation, current flows through the patient. C, tumor ablation results from the heat that is generated. D, the size of the microwave field is determined by the wavelength and antenna design. Which of those is false? And last question, number 10. Which of the following electrosurgical waveforms used with a monopolar instrument would be expected to have the greatest interference effect on a cardiac rhythm management device? Is it coag? Is it cut? Is it blend? Or is it all are equal? Great. So thanks. It's good.
So we have about a few minutes left. Is there any questions from the audience? If you do, please step forward to the microphone, identify yourself. So having summed up, so to speak, this session here, what do you, question to the panel, what is the most common problem you think that occurs in the operating room with any of the energy devices that we have discussed today? We'll start at the very end there.
Specifically with the ultrasound device, I think the most common problem that you can encounter is inadvertent holoviscous injury, specifically with the aspect that I talked about with the high increased temperatures, even when the blade is deactivated. So that's probably the most common problem. It's usually not seen when you try to grasp or push a bowel away with you think the bowel is deactivated and is cold, and is absolutely not. Could be as high as 200 degrees or above. So,
David, in your practice?
I would say that the most common problem that I observe is that most practitioners of the use of electrosurgical and microwave devices don't have an understanding of how they work, and therefore don't use the devices to their maximal potential and do put patients at risk. So I know it's a politically correct answer, but I feel strongly about that.
Well, that's a very good answer. That's why we're all here today, I think.
From the anesthesia standpoint, then I guess sort of the same thing, where you tend to have a surgeon who wants to use whatever their normal device is, and when you have a patient who may need a little more flexibility, they don't have the familiarity to move on to possibly a different sort of device.
Thank you, James. Any last comments on that?
In agreement to what is being said, I think the most critical factor is inexperience or the wrong application for a given instrument. I frequently hear and see people using the wrong device for the wrong reasons, I think. And sometimes the wrong or the right instrument is chosen, but the provider doesn't have much experience with a given instrument, and I think that's when you see problems happening.
I would say in pediatric surgery, the most common error I see people making, and is the one that I emphasized, is people get the dispersive electrode wet on a child, because you cannot sloppy prep a child, and they're so small that either from your irrigation, from fluid drainage, or from your prepping, the dispersive electrode gets wet. And most of the time you won't get into trouble with that, but if you do end up getting a burn, it can very easily in a neonate be circumferential and they're suddenly critically ill. And I think the other error that people make in pediatrics is they just don't think to check their settings before they start, and then somewhere mid-case people will say, oh, what are our settings on?
Thank you very much. We have one question from the audience. Please identify yourself.
Yes. Jamie Loggins from Maine. I want to thank the committee chairs and the panel for an embarrassingly insightful talk for me this morning. My question or comment is, one of the things that I have seen coming out in the spirit of single incision type of laparoscopic surgery is, I know that there's one manufacturer that actually has a high dexterity device to deliver electrical energy, and I'm wondering if any of the panel has experience using this device or any similar ones, because a couple of thoughts crossed my mind. One, an increased risk of direct thermal energy, but is there going to be something more going on with the direct coupling type of injury now that we have insulation over a flexible joint? Those would be things that were concerns of mine when I first saw these instruments.
Let me open that question up to the FUSE members in the audience, because I think most of the panel is not so familiar with MIS. So maybe Malcolm, do you think you can answer that?
Well, I think it was Churchill who said, "Those who don't know history are condemned to repeat it." In the gynecological literature, the use of monopolar instrumentation through the original single port devices were really called operating laparoscopes. And this actually creates quite an opportunity for capacitive coupling with monopolar instruments to the scope itself. There are all sorts of opportunities for capacitive coupling to the various instruments that are crossing over each other. I think that's what you're pointing out. So I think this is an area that is going to be really ripe, prone for some catastrophic outcomes unless we really pay attention to it very carefully.
Dana, do you know what this gentleman is talking about in terms of this device that's on the market? Maybe you can comment on that.
I think you're referring to a monopolar cautery device that articulates. Yeah. So, I mean, clearly with the articulation of that device, it's going to come down. I've used that device on one or two occasions and don't have a ton of experience with it, but it will come down to the degree of which the insulation around that is able to uphold throughout that case. It is a disposable device, so it's not used repetitively, and so that adds to its benefit. But clearly, if there's breaks in that, that'd be problematic.
Well, actually, just a sec. The insulation doesn't matter. You can, and we're going to show you in the lab today. We'll couple multiple times through multiple layers of intact insulation. So that's I think the point is that many of you actually charged a toothbrush this morning or last week, and you noticed that there were no actual electrodes on your charger. That charging goes through the insulation twice, once in your toothbrush and once at the base of the charger. So you can capacitively couple through insulation. So insulation integrity is important to prevent the high current density injuries that occur in zone 2, thank you, and 3. But it does not protect against capacitive coupling. And this is really what can happen in this circumstance is you can get capacitive coupling because in zone 2 and 3 you're having crossing over of various instruments that are activated. So that's the real worry.
So that's where the future is, and Fuse is designed to pick up all these new instruments, and I think you'll hear more about that next year when we'll do our second course. There's one more question from the audience here, please. Last question.
Joe Dodd from Missouri. We're seeing more and more elderly patients, and it seems like everybody who has heart failure gets a defibrillator implanted. We see a lot of them, and the reps are getting increasingly resistant to doing checks afterwards. My question is, how much do we need to stick to our guns? Because I'm guessing you've obviously seen this resistance. There's a lot of devices, very few reps, increasing number of operations, and the devices have a better safety profile than they did initially, but it's still not totally 100% safe. What's our exposure here?
Yeah, it's hard to say. As you said, the numbers are going up, and I honestly feel most of us are, including my hospital, are fairly lax when it comes to dealing with the devices. We have a huge cardiology electrophysiology service who wants absolutely nothing to do with us for the most part, and it's not worth their time. So we have to be fairly forceful about getting the fellows at some point up. Again, it doesn't have to be within, an hour of the surgery. It can hopefully be while the patient's still in house. But on the rare instance where you're doing an outpatient procedure, I shouldn't say rare, I guess it's increasingly common. When you're doing an outpatient procedure with significant use of electrocautery and, in some proximity to the device, and you've applied a magnet to it, I really think somebody needs to check it, even if it's a telephonic to their cardiologist. We need to kind of start sticking to our guns, because somebody's going to go home, have an episode of VF or feed tac, and not get shocked when they're supposed to.
Thank you very much. That concludes our session. Thank you for coming.